Thank you for joining us. My name is Barry Erickson, and I am Community Engagement Coordinator at Wheaton Public Library. Tonight we have another in our ACES series of programs. ACES stands for Aging and Caregiving Engagement and Support. With this program series, we are creating a consolidated source of reliable local information for our community seniors. And tonight, of course, we are focusing on eye health. Dr. Nisha Gupta is board certified and a member of the American Academy of Ophthalmology. After completing medical school and her residency in Virginia, she received specialized retina training at the world-renowned Bascom Palmer Institute in Florida. Her private practice, Gupta Eye Center, opened in Wheaton in 2019, where she does general eye exams and takes care of patients with a variety of conditions, including diabetes, macular degeneration, and glaucoma. With so much expertise and great information to share with us, Dr. Gupta, we're delighted that you're with us. Thank you so much.
Oh, thank you. Thank you for having me. And thanks to everybody who is joining us tonight, giving up your Wednesday evening to hang out with me and learn a little bit about your eye health. So we're going to be talking about a variety of conditions that can affect your eyes as you get older. I'm going to show you, this is kind of a brief outline. So we're going to do a little bit of anatomy, talk about a variety of conditions that do tend to occur more in older patients. And then we'll leave some time for questions at the end. So I'm going to start with very, very basic anatomy. Don't be too alarmed here. So again, when we look in the mirror, the only thing really we're seeing is a very small part of the eye. So we're just seeing right about here, the eyelids. The surface of the eye is called the cornea. It's clear. And then behind that, you can see the colored part of the eye, which is the iris. The white part of the eye is called the sclera. So you're not really seeing a whole lot. You can see how much of the eye is really like a ball back here, and there's a lot going on back here. On the outside here, we have lots of muscles that attach to the sclera, and that allows our eyes to move in all the different directions. Here is a cross section, so you can actually see the inside of the eye. So again, we have the cornea, which is the clear layer in the front. If you wear contact lenses, the lenses are sitting on the cornea. This is the colored part of the eye, again, the iris. There's the black circle here, which is the pupil. That's what becomes bigger when we do dilated eye exams. Behind that is the lens. This is where we get cataracts. The space in the back of the eye is actually filled with a gel, and that's where we get floaters. The back layer of the eye is called the retina. This little space here specifically is called the macula. That's where we get macular degeneration. And then right here is the optic nerve, and that's where glaucoma occurs. So we're going to be talking about a lot of these things tonight. Again, and let me know if you have any questions. Are there any basic questions before I go forward on the anatomy?
Not so far. I think we can go ahead.
Very good. So the first thing I'm going to touch on is dry eye syndrome. We do tend to see dry eye even in younger patients now, but it is very common as we get older. A lot of parts of the body are drying out, including our skin and mouth, the eyes. So the basics for dry eye syndrome, there's kind of two tears. So one is we don't produce enough tears. The tears are tending to come from the lacrimal gland, which is up here. So if that gland is damaged, we won't have enough. There are some conditions, something like Sjogren's, which causes dry tissues. So the eyes are one of them. The mouth is another. The more common reason is that the tears evaporate from the surface. So this can be due to a dry environment. Blinking issues are probably the more common we see nowadays because we all use a lot of screens. So when we're looking at a screen, we don't realize it, but we don't blink very much. And so that causes the tears to evaporate from the surface. This can also come from any sort of lid abnormalities. So eyelid cancers, or if there's been a tear in the lid, something like that can also lead to the tears evaporating from the surface. And with dry eye syndrome, there are a lot of symptoms, and every patient is different. Some patients experience a lot of them. Some patients may experience one or two. Some patients don't really experience anything at all. So there's a very wide spectrum of what patients are feeling and how much patients are feeling. Probably one of the most common things is actually increased tearing. And it sounds counterintuitive, but what happens when the eyes get dry, the body senses that the eyes are dry and it needs more tears. So the body's response is to make more tears. So if you have increased tearing, very often it's because the eyes are dry. All the rest of these symptoms can also occur to varying degrees. So blurry vision, a sandy or gritty sensation in the eye, sort of feeling like something is in the eye, irritation, burning, redness can occur with dry eye, and light sensitivity, especially when the dry eye is a little bit more severe, a little bit more pronounced. There's also a wide variety of treatments now we have for dry eye. The most common and probably the most conservative treatment is just with using lubricating drops. These are all very readily available over the counter. So you can really have your pick on which ones you want to try. I often will tell patients to try different brands, to mix and match, see what works for you. And you can use those a few times during the day. The kind of next step up is to use a gel drop. So these gel drops are a little bit thicker than a normal tear. They'll stay on the eye a little bit longer. Ointments are even thicker. So they actually come in a tube. The tube itself, the cream itself is a little bit thicker and it makes your eyes a little bit blurry. So I tend to recommend to use that at nighttime before you go to bed, but it can be very soothing and lubricating through the night while you're sleeping. So these are very conservative things you can do on your own. If these don't work or you're feeling like you're using these a lot, then we move on to the more invasive things. So prescription eye drops, they can work really well for some patients. They don't work for everybody. They're kind of hitting the inflammatory sort of reasons why we get dry eye. So those we can use for many patients. They're a little bit expensive and they do take some time to work. So really we're picking the right patient to really use those drops for. Frontal plugs are another way to increase the tears on the surface of the eye. So if you looked really closely in the mirror, you'll see in your upper and lower lid, there's almost like a little mountain there. There's a little hole there, and that hole leads to tubes that go into the nose. And we can actually block that little hole with the plug. So the plugs can be permanent or temporary. And once we block it, that means the tears won't drain out throughout the tube into the nose. They'll stay on the eye a little bit longer. Again, these can work really well for some patients and for others they don't. So sometimes we will try them and see if it's a good option or not. The other things also are very conservative things to do that anybody can do at home. So omega-3 vitamins have been shown to help patients with dry eye. There are certain patients who can't take it for whatever reason. If you're on a specific medication, maybe another doctor has told you not to take them. So we would avoid it for you. But overall, most patients can take omega-3s or at least supplement in the diet with flaxseed, fish, things like that. The other thing that can help is using a humidifier in the winter. So winter here, it tends to be very dry. We have a long winter. So using a humidifier will actually add some moisture to the air, and that moisture will go to the eyes. Same thing for the summertime now. You don't want to be using fans in the summertime. So the ceiling fans will create an artificial wind that actually will strip off some of the tears on the surface of the eyes. So if you can avoid it, that will help also. And lastly, taking breaks while you're using any screens. So if you're using a computer, your phone, iPad, television, any of those screens, even reading a book, we tend to stare because we're focused. And so if you take lots of breaks every 20, 30 minutes or so, you look away from the screen, blink your eyes a few times, and then you come back to it. You can also use drops if you're doing one of those activities for a long time. This will basically redistribute the tears on the surface of your eyes, make sure that they don't get very dry. All right, so any questions on dry eye?
Yes, Dr. Gupta, I'm just wondering, do sometimes people have trouble wearing contacts as they grow older, especially due to the dry eye situation?
Yes, so the contact lenses are basically seen as a foreign body in the eye. So it's not meant to be there. And what it's doing is it is stripping off some of those tears from the surface. So many patients who wear contact lenses for a long period of time, and especially as we get older, because the surface is drying out, they do feel some dry eye symptoms. Generally, drops will help with that. So I usually recommend using some lubricating drops while using the contact lenses. And then obviously trying to stay out of the lenses for as long as possible. So minimizing the time during the day that you're putting them in. I have some patients that'll say, I'll use them for 16 hours a day straight, peel them off at nighttime, and then go to bed. But that's really too long to be in your contact lenses for one period of time. So you want to try and limit it to about 8 to 10 hours if possible.
Okay, great. Thanks. I think we're ready to move on.
Perfect. Okay, so I'm just going to touch on presbyopia because this is also something that affects pretty much everybody at some point. Presbyopia just is the fancy term for not being able to read up close. So when you can't read up close, obviously you need reading glasses or something to help with that fine print. For most people, this will actually start somewhere in the 40s. Some people are lucky and it will start maybe in the 50s or so. And the reason why we get it is because the muscles of the eyes get tired as we get older. And so because they get tired and fatigued, they can't look up close as well as they used to when we were young. So this is something that happens to pretty much everybody. Now, there are certain cases where I've had patients say that they get better over time or they stop needing reading glasses. And this can happen with things like cataracts or just with certain patients, we will see it. But overall, at some point, most people will need something to correct for the reading vision. I recommend glasses for the most part. Now, there is an eye drop that recently came out. I'm sure some of you have heard of it, called Vuity. Vuity is meant to help you to see up close, to focus up close without the need of glasses. The drop itself is basically an eye drop that constricts the pupil. So it just makes your pupil a little bit smaller. It lasts for about 4 to 6 hours. You're only meant to use it once a day. So it's not something that's going to work all day long, and you're not supposed to be using it multiple times a day. There are side effects with it, and I think a lot of ophthalmologists at this point are not actually prescribing it because of the side effects. And we haven't really seen what the perfect kind of patient would be for this. So it's a lot of trial and error. I think the ophthalmologists who are prescribing it are trying to figure out who is it best for, who is the perfect patient to use that eye drop. The side effects tend to be headaches a lot, dizziness, and the kind of feared one is something called a retinal detachment. And that is where the retina layers in the back of the eye separate and you can actually lose vision from that. So I think that's where a lot of our kind of timidness comes from, why a lot of us do not want to prescribe it because we fear that complication. But it does work for some patients. And I think it will take a little bit of trial and error to figure out who's the best patient. Any questions on presbyopia?
Not right now. I think we can move ahead.
Perfect. All right, so we'll get to probably the big topic is cataracts. Cataracts are also something everybody gets. You cannot avoid it. I've heard patients tell me, well, there's drops out there, there's medications out there to avoid getting them. Unfortunately, that's not true. All of us will get cataracts at some point. They usually actually start in our 50s and 60s, and they progress over time. And you can see here in this picture, the arrow is pointing to the lens where the cataract forms. So we're all born with this lens, and over time, the cataract is growing on the inside of the lens. And the cataract itself is essentially proteins that are breaking down in the lens. And as those proteins break down, they become a little bit cloudy. And so we see that as a change on your exam as a color change. And then for you, you'll notice that as a few different symptoms, most commonly blurry vision, looking far away. So we'll go to symptoms. So again, blurry or cloudy vision is the most common symptom. Many patients will come in complaining of nighttime vision issues, especially with driving. Glare, especially from headlights, can also be a problem with cataracts. Some patients will notice a difference in colors or something called contrast sensitivity, which means you need brighter light to see things, especially when it's dark out. And the big thing to note is with cataracts, you shouldn't have any pain. So the nice thing is it just grows and grows and doesn't cause you any pain and doesn't usually cause any issues until you get to the point where it's grown enough where it's causing a little bit of blurry vision. And I'm going to show you a few pictures of patients of mine with cataracts. This is a patient that has the cataract in the center here. So it looks kind of green over here that you can see. And this is the most common type that pretty much everybody gets. Again, it's called a nuclear sclerosis cataract. And it's the one that occurs over time, and it just grows over time very slowly. It is not something that's going to grow overnight, and over time will slowly affect the vision for distance. This patient also has another type of cataract that's growing in the front part of the lens. And you can see these kind of white spokes. So that's called a stellate cataract. And this itself can cause a little bit more of the glare. So while this one can also give glare, this one tends to be a little bit more so. And both of these happen in all types of patients. I mean, this can happen to anybody. This is a patient who also has that nuclear sclerosing cataract that's in the center here. That's this greenish color. And in the back here, you can see this sort of mottled, kind of wrinkly looking cataract. This is occurring on the back part of the lens and has a very long name called a posterior subcapsular cataract. Again, as far as the cataract goes for us, it doesn't mean a whole lot. We can see it on exam and we note that it's there. We specify the type. But for you as a patient, the most thing you would notice different from this type of cataract is potentially some blurry vision looking up close. And it can also give a little bit more glare than your run-of-the-mill nuclear sclerosis cataract. This is a patient with a mature cataract. So you can really see it here with all these white spokes kind of covering the entire lens. So this is one that's just growing for a very long time. Perhaps this patient did not care to really take care of the cataract, or maybe they didn't have access to care and they weren't able to do anything with it. So this is just what would potentially happen if you let the cataract go and you didn't really do anything about it as far as surgery. This is potentially what could happen. This person probably does not have very good vision because they're not able to see through all this cloudiness of the lens. So what do we do for the cataracts? The good thing is in the beginning, we don't have to do anything. So when you first start getting a cataract, most of the time you're not going to even know you have it. It's something that we'll see on your exam. We might know, we might tell you, we might not. I mean, they're so common in the beginning, they're not really causing any problems. So I have many patients who will come to me in their 70s and 80s saying that they didn't even know they had the cataract. And most likely it actually started 20 years prior. The good thing is because they're not dangerous, we just can leave them alone and watch and wait and see what happens with time. Everybody is different, so they affect in different ways. They can grow more quickly in some people, and in others, they grow very slowly. So time is usually what will tell us what will happen. The glasses are a great kind of treatment for cataracts that are starting to affect the vision. So once the vision is affected, the first thing we try is glasses, because usually that can help with your distance vision, potentially your near vision. And when you get to a point where the glasses don't help, so if you're still seeing blurry, if you still have a lot of glare, if you're not able to do your daily activities, that's when we start thinking about surgery. So most of the time, patients are telling us, I think I'm ready because I can't really see very well. And that's when we start thinking about doing surgery. It's a surgery you go into the operating room for. You get to go home the same day, and it's done very, very widely throughout the country. Many procedures are done every day. So are there any questions on cataracts?
I think you answered all the questions. I was going to ask you, like, when do you decide to go ahead with surgery? But it sounds like it's really determined more by the patient than by you as the physician.
Yes, I mean, there are very rare times where we're telling patients that it needs to be done. So if one of the cases is if the cataract is so dense that we cannot see into the back of the eye. So especially for someone who's a diabetic and I need to get a good view to the back of the eye to look at the retina, or somebody who has macular degeneration and I have to look at the retina, if I cannot see it, that would be one instance where I'm telling a patient you really need to be thinking about having cataract surgery so we have a good view to the back, make sure it's still healthy. But otherwise, yes, for the most part, if the vision is down and patients want to have it done, that's when we'll do it.
Okay, good to know. Thank you.
Sure. All right. So I'm going to move on to glaucoma. Now, glaucoma is something that's very frequently confused with cataracts. Now, cataract, again, is something we all will get, cannot avoid it. Glaucoma is something completely different. Not everyone gets glaucoma, and it's usually more serious than cataracts are. So the basic definition of glaucoma is damage to the optic nerve, which is here, and that damage causes you to lose peripheral vision. So that is the true definition of glaucoma. We do have several types of glaucoma, and we do a lot of testing to determine if you have it or not. So I'm going to start by showing you some pictures, and I'll go through some of the tests that we tend to do for patients when we're trying to figure out if someone has glaucoma or not. The first thing we want to do is your exam. So we do a dilated exam looking at the nerve. And I like this picture because it shows you what a normal optic nerve should look like and what it can look like in somebody who has glaucoma. So over here on the left, this is a normal optic nerve. You can see it has a nice orange rim here, and it has a very tiny circle in the center that's a little bit pale yellow. And this is what we're looking at in patients who we are suspecting have glaucoma, maybe who look suspicious for it, or in patients who have it. So we're monitoring the size of this circle here. And you can see in the second picture how large that circle is. So you can see it's much bigger. And so in patients who have glaucoma, this circle is getting bigger over time because of the damage to the nerve. And finally, in this one, you can see there's basically no orange rim. There's nothing on the edges here. This is a very, very advanced case of glaucoma where really all they have left is that central circle. It's grown so large, pushing out all the healthy tissue. And this is a very damaged optic nerve. Now, you might have heard something about eye pressures when it comes to glaucoma. And eye pressures are something that's part of our workup. So I cannot look at just an eye pressure or look at just an optic nerve and say you have glaucoma or what type of glaucoma you have. We have to look at a few different things and put all the pieces together to determine the final picture. And the pressures are one of those pieces of the puzzle. So the eye pressure itself is something we would measure at every visit. And it can be high for some patients, and it might actually be within the normal range for others. So there is something called normal tension glaucoma, where the pressure is actually normal or considered a normal pressure. So again, it's part of the puzzle. It's not exactly that every person with glaucoma has a high eye pressure. So I'm going to go through a few other pictures so you can see what the tests are that help us determine whether or not somebody has it. And this picture shows a picture of the optic nerve. It's called ocular coherence tomography, or OCT. So if you have glaucoma or you know someone who has it, these pictures are something we do every year to see how the damage is to the optic nerve. So over time, we'll get these to see if there's any change in the nerve fibers, see if anything is getting worse. And the picture on the left, this is somebody with a normal optic nerve. I think probably the easiest thing to see here is you see these green pie graphs on the bottom. So green is good, but I also will point you to this map here in the center on the top. And you can see how these fibers, these look red and white up in the top and the bottom. So those are healthy nerve fibers. That's what we want. So that's a normal optic nerve. And you can see the difference between this one and compare this to the right one. So this is a patient of mine who has advanced glaucoma, and you see that red and the white, there's basically none. So this patient has very advanced glaucoma where they have lost a lot of these fibers. And even down here, you can see how everything looks pretty red. So those are the areas where they've lost a lot of these nerve fibers, causing the damage, and then eventually losing the vision because of all the damage to the nerve. The other test that we do pretty frequently, either every 6 months or every year, depending on how severe the glaucoma is a visual field test. So if any of you have had the visual field test, it's probably the least favorite among all patients. It does take a little bit of time. Essentially, you sit in a machine, the machine will flash a lot of lights at you, and every time you see a flash, you click a button, and it maps out your peripheral vision. And the reason why this is important is because this is our map. This is the way we see if your vision is worsening or not from the glaucoma. So these are a few patients that will show you where the damage is. So this person, this is the right eye, and you can see this pointed part is pointing towards the nose. This is out on the side. This spot right here is a normal blind spot. So everybody has that. So in a patient who has no visual field defects, they at least should have this little blind spot. And then you see all this other area here that's gray and black. So all of this is the area where this patient is not seeing. They're not clicking the button. And so this, I would already say that they've lost some visual field from glaucoma because they're not clicking the button. They're not seeing the lights over here. And you can see how it just gets worse and worse. So these are two other patients. This one has much more damage. Really, they're not seeing very much at all around here, all black. And this person has very advanced glaucoma, barely seeing anything, maybe a tiny bit in the center. But for this patient, not only is their peripheral vision gone, but their central vision is also very severely impacted from the glaucoma. So what do we do for glaucoma? I mentioned about having high eye pressure. Sometimes it's actually normal, but really the best way we know how to treat glaucoma is to lower the eye pressure. So no matter what it is, if we can prove, if we show on your testing that you've had some vision loss from glaucoma, whatever your eye pressure is at that time, it's too high for you. So while a pressure of 15 might be good for me, it might not be good for somebody else. So the way we treat it initially is with eye drops. Now, these are all prescription eye drops. They are meant to lower the eye pressure. There are a few different brands, a few different companies that make these, and they all work in different ways. So we can actually stack them. So we have some patients who are on 2 drops, maybe 3, maybe 4, because they all are working in different ways. They will work together to bring the eye pressures down. Another option is to do a laser procedure. Sometimes some patients will do both. So we'll use some eye drops, they'll have laser, and then we see maybe we can take off 1 drop, maybe we see if we can take off all the drops. So we might do a combination therapy. If these don't work, then the last option is surgery. So if somebody is still losing vision after trying drops and laser, then really our final choice is to do surgery. The surgery essentially is still to try and get the fluid to flow more easily, to lower the eye pressures, and keep that optic nerve protected so that we're not losing any more vision in the periphery. So again, surgery is a very advanced case. It's not something that we would rush to because usually the other treatments are working. Are there any questions on glaucoma?
Actually, right as we were transitioning from cataracts to glaucoma, a couple of cataract questions came in. Should we go ahead and address those now?
Yeah.
Oh, okay, and that'll give people a chance to maybe formulate any questions that they have about glaucoma. Someone is asking, how painful is cataract surgery, and how long does it take, maybe the surgery itself and then also recovery?
So surgery, you should not feel anything. So it's painless. During surgery, you get some anesthesia. Most people will be able to actually get some local anesthesia, so you will not be completely asleep, but you should not feel anything. So if you do, you have to, scream out or something. But I've never had that happen because usually you're so sleepy, you have no idea what's happening. So you won't feel anything during the surgery. You won't even know what's happening, and then we wake you up after, and you get to go home. The surgery itself, as long as there's no complications, of course, with any surgery, there can be complications, but otherwise it's usually pretty quick, about 15 minutes for 1 eye. We don't tend to do 2 eyes at the same time unless there's a very specific reason. Maybe someone who's disabled and can't come back to the operating room. Occasionally we do see kids who have cataracts. So for kids, we want to do both eyes if we can at the same time because they have to go under general anesthesia. But otherwise, for the 1 eye, 15 minutes. And then the recovery time is, again, if there are no complications, fairly quick. So you come back to the office the next day. We take a look, and a lot of patients are seeing better the next day. You have to use some eye drops for a few weeks, about 2-3 weeks or so. And then that's pretty much it. So the recovery is pretty quick. And then if everything goes well with the first eye, most patients, if they need the other eye done, also it can be done probably with about a couple weeks after the first eye is done.
Okay, great. Thank you. And someone else is asking, with cataract surgery, it's correct that you are putting in a new lens, you're implanting a new lens? Okay.
Yes.
And the question is, how does the doctor determine which lens to implant?
Yeah, that's a good question. So I didn't really go over specifics of what happens during surgery, but yes. So I'm going to go back, actually, let me show you the picture of. So what happens during surgery, we make a small cut in the cornea so that we can put our instruments in. And there's a shell around the cataract. We leave this shell behind. We make a cut in the shell. And again, if you think of this, this cataract, you can see how it's going back here. The cataract, think of it kind of shaped like an M&M. The lens is shaped like an M&M. So you got the shell on the outside. So that shell we're leaving behind. And the chocolate on the inside, that's the cataract. So we're removing all the chocolate. And the way we can access the cataract, we make a cut that's a circular cut on the top part of the shell. So we remove that top part of the shell. So now you can see into where the cataract is. We use very small instruments to break it up. And then it's almost like a small vacuum that we take out those pieces. So now we're left with this shell behind, and that's where we implant the lens, and it's a flat lens. So it just sits right on the inside here, and it scars into place in about 6 to 8 weeks after surgery. And that lens, the way we know the measurements is we have machines that are very fancy and have equations that I would not be able to discuss, but those are the machines are basically calculating what prescription is meant for you. So each of those lenses are specific to the patient. So we would use the lens measurements that we've gotten for each individual person, and then we pick the lens based on those measurements. There are different types of lenses that we can use nowadays also. Most of the lenses will correct for distance, and then you wear reading glasses afterwards. Now there's what we call premium lenses. Those lenses can actually correct for both distance and for near. But these are something to talk about, of course, if you're at that point, or if you're thinking about cataract surgery, talk with the surgeons about what option is best for you, because these are not meant for every person.
Okay, great. Thank you. And we do have a glaucoma question. Someone is asking, is the damage done by glaucoma reversible?
No. So that's kind of the difference between cataracts and glaucoma. So if you're starting to lose vision from cataracts, we can fix that. So we can take it out and we put a new lens in, and you can see. With glaucoma, once the vision is gone, it's gone permanently. There's no way to bring it back. And so that's why it's so important for us to do a lot of the testing, even though it's annoying to do visual fields and things like that. That's why it's so important for us to do that. And we have to do it at least once a year to make sure things are not getting worse, because if we start seeing the vision loss and we don't treat it, then the vision loss can become worse, and there's no way to bring it back.
Okay, all right. Let's go ahead and let you continue. We'll keep some of these other questions for the end.
Okay, so I'm going to move to the back of the eye now. We're going to talk about macular degeneration. And you'll notice it says age-related macular degeneration. So this is a disease of the older population. It's usually around 55 and up is where we tend to see this. We won't see it in patients younger. I think I have seen one patient who was in their late 40s, and we're still not convinced that they had macular degeneration. So it is something that happens when we get older. There are two forms, the dry and the wet. So the basics of macular degeneration is basically in the area of the macula, there's been some deposits, or there can be some damage there that cause the vision to change. The dry form is basically that. It's dry. There's no fluid there, no bleeding. It's just some protein deposits. It's the more common form, and usually doesn't have as much vision loss as the wet. So the wet form is where there's some fluid in the back part of the eye. So either some bleeding or some fluid that's been leaking out from blood vessels. And that in itself can cause a much more devastating vision loss than the dry form. And I think the better way to sort of explain what this looks like is with pictures. So I'm going to show you a few pictures here so you can see what the differences are, and then we'll talk about the treatments. So this is a picture of a patient of mine with a normal retina. So if you see, this is pretty large. I mean, there's a lot of space back here. These are just the eyelashes, so don't worry about that. And the area that we're focusing on is right here, this really small space. This is the macula. So this is what a normal macula looks like. There's a little dark spot in the center. That is a good thing. But otherwise, it's pretty clear. There's no spots around here. And if we contrast that with a patient who has dry macular degeneration, you see all these yellow spots pretty much everywhere. So these yellow spots are the hallmark for dry macular degeneration. And what they're called drusen. And what they are is protein deposits that are sitting on the bottom layer of the retina. And so we see them as these yellow dots. You can see there's some small ones, there's some larger ones, but this is really the hallmark for dry. So there's no fluid here. It's just some proteins that are collecting over time. This patient has a fair amount of them. We have some patients who maybe just have a quarter of that. So that's why we follow this to see if it's getting worse, if there's more protein deposits. They can change over time. Sometimes they start to combine into, two or small ones might combine into one large one. So these can change over time as one gets older. And then this is actually a patient with a more advanced case of still dry macular degeneration. But you see here, these are the drusen, so all these yellow deposits. But in the center here, you see it looks kind of lighter colored, and there's these really bright kind of reddish orange lines underneath. So this is something called geographic atrophy. And what happens here is this layer of the retina actually is lost. So there's some tissue there that's completely gone. And what you're seeing now is you can see these blood vessels that are under the retina. And so you can see them more easily because now the top layer has gone. So if you look here, you can see this orange layer. That's that layer that has disappeared here. So this is an advanced stage of dry macular degeneration. This person does probably have pretty decreased vision here. Again, it's not as common. It takes a while to get to this point, but it certainly can happen over time in patients with the dry form. Now, anybody who has the dry form theoretically can convert to the wet form. The wet form is where we see bleeding. So you can see the bleeding over here. Or if it gets to a point where it's the later stages, it becomes a scar. And the bleeding comes from blood vessels that start to form underneath the retina that are not supposed to be there. So in a patient who has macular degeneration, the environment of the eye is different from somebody who doesn't. So there's different chemicals, a few other things that are floating around back there in the environment of the back of the eye. And it can lead to some blood vessels that start to grow that are not supposed to be there. These are abnormal vessels. And these vessels are very fragile and very prone to breaking and leaking out into the space. So this person had some blood vessels that broke open, and you can see now all the bleeding here. Sometimes with or without treatment, what happens is it becomes a scar. So this person has a lot of scar tissue. This is kind of an end stage wet macular degeneration. Unfortunately, this person's vision is not going to be great, and there's not too much more we can do at this point when it's become a scar. But that is rare, does not happen very often. So the pictures that we do for macular degeneration, it's the same machine as for glaucoma, the OCT, but now we're looking at the macula instead of the nerve. So for the most part, with a lot of macular degeneration cases, we can find it on exam. So you can see all in the pictures I've shown you already, we can see that when we're doing the dilated exam. Sometimes it's a little bit tricky. If we're not sure if there's something there or not there, or we really want a better picture, we do the OCT. So what the OCT does for the macula is it actually shows us all the layers underneath that top layer. So it takes a cross section through the macula, and now you see here all these different layers that are making up the macula. So it's a little bit tough to see, but if you can see this light, dark, these are all the layers that make up the retina. This is a person with a normal macula. You can see the bottom layers going nicely across. And then eventually you have this little dip here. This is where the highest concentration of our cone cells are. So the cones let you see color and fine detail. And so this little dip is very vital to our central vision. And this is a patient with dry macular degeneration. So all those yellow spots I had shown you before are actually these little bumps in the bottom layer. So if you follow this red layer on the bottom, you can see all these little bumps. And those are the drusen, the little protein deposits that are collecting in patients with dry macular degeneration. And this patient probably still seeing very well. There's nothing we need to do here, but this is definitely starting to form kind of these drusen and this dry sort of macular degeneration. And then if we contrast that with the wet, so with the wet form, so now again, you see this bottom layer, and now you see all this stuff up here, and now you see this kind of mountain. So this right here is where these new blood vessels were forming. They're starting to encroach into the space of the retina. So this is the normal retina out here. And now you see you have all this stuff collecting in here, and it's starting to leak into the space. So this dark area here You can see a dark pocket here, one tiny one here. That's all either fluid or bleeding that has seeped into the retina space. And that's what we're basically looking at when we see the wet form of macular degeneration. So if any of you have macular degeneration, you're probably very well versed in these pictures because this is something we get at every visit to make sure that you haven't converted to the wet form. Or if you have had the wet form, this is how we monitor the treatment. So the treatments that we have, unfortunately, there's not a lot, and there is no cure for macular degeneration. So once you have it, you have it. We're just sort of monitoring it, and there's some things that can delay the progression of the disease. So one of the first things is with the AREDS vitamins. The NIH did a large study, thousands of patients, where they came up with a formula for just vitamins to protect the back of the eye. So it's something that's over the counter, you can get without a prescription. And I tell all my patients with macular degeneration to take them because what they found was if you took those vitamins, it doesn't stop the progression and the disease, but it does slow it down. So it lowers the risk of getting to that advanced stage and converting from the dry form to the wet. So those are really important to take. The other thing I'll give to all patients is something called an Amsler Grid. So I'll show you what the grid looks like. And you can see on the left side, this is a normal grid, and there's a little dot in the center with a lot of lines around it. And this is something that you could check one eye at a time and monitor your vision at home. So if you check, you stare at the center dot here, all the lines around it should look straight. And you can see on the picture on the right how this is sort of a person who maybe drew it out and they were showing what they might be seeing is either a dark space or these wavy, distorted lines. Sometimes patients will say that they're missing some of the lines. And that's sort of an indication for you that it's time to go see a doctor because there's been a change on your grid. Now, some of you, if you have already some advanced disease, you may already have some of these things where you're seeing some wavy lines in some spots for the grid, and that's okay. We're looking for changes on the grid. So if you have anything that changes from your baseline, that's when you know you need to be going to see somebody pretty soon, if not right away, so that we can make sure that there's nothing new on the exam. Low vision tools are something that we use for patients who've had advanced disease or have lost vision from macular degeneration or really from anything, glaucoma, anything else. They include magnifiers or really specialized glasses. There are a couple of institutions that will help with that. Vitreous Institute is here in Wheaton, the Lighthouse is in Chicago, and they have a lot of resources to help patients who have lost vision from something like macular degeneration. A healthy diet and no smoking, so important for general eye health, but especially for macular degeneration. The smoking actually has been proven to make wet macular degeneration worse and to kind of encourage that transformation from the dry to the wet. So really encourage you not to smoke and to quit if you can, if you are smoking. Blood pressure and cholesterol also important to keep under control. And finally, for wet AMD, we have injections now. So for dry, there's really not a whole lot we can do. There's a lot of research going into what we can do for the dry. But for wet, about 20 years ago or so, we started looking into doing injections of medicine into the eye. The medicine itself actually clears up the blood and the fluid that's collected in the back of the eye, and we can actually recover a fair amount of vision if we catch it early and if it's not too much to begin with. So these have really revolutionized treatment. If you're someone who has wet macular degeneration, you know how it goes. We give one injection every month, and then we see if we can start to back off and we space out the intervals. But the injections really work very well, and we have a few different types, and there's new ones that have been coming out too. So very exciting to have some more treatments to really help with the vision. So what questions do we have for AMD?
A couple of people are asking, are there ways to prevent macular degeneration before it even occurs?
Not really. This will pretty much happen if it's going to happen. It's very strongly linked to family history. So if you have blood relatives who have it, you're at higher risk. Really the only way to kind of keep the eyes kind of healthy are just eating well and don't smoke. Smoking is really bad. But otherwise, there's not a whole lot you can do.
Okay. And someone else asks, a person who's taking blood thinners more at risk, particularly for wet macular degeneration?
I mean, if you're on blood thinners, you're unfortunately going to be at risk for certain parts kind of the eye for bleeding. So even on the sclera, on the white part of the eye, the blood vessels there can break and you can get what we call a subconjunctival hemorrhage. If you look up pictures, they look horrible, but they mean nothing. But those can happen in patients who are on blood thinners. In the back of the eye, theoretically, I guess, yes, you could be a little bit higher risk of developing wet macular degeneration, but the blood thinner is much more important. So we don't really consider that risk. You have to stay on it. If you're a diabetic, I guess theoretically you could have some bleeding from that. There are just in general, we've seen a couple of cases where the blood vessels become, the very fragile or whatever it is, even the normal ones. So sometimes they can leak out as well from being on blood thinners. These are pretty rare though. They don't happen as frequently. If you're going to develop the wet form, you probably would have developed it anyway, even if you're on blood thinners. So I wouldn't worry too much about the blood thinners. If you're taking it, the reason you're taking it is far more important. So you don't need to worry about the eyes too much.
Okay, great. That's good to know. And it looks like there's one more question related to this. Someone commented that their doctor said not to take those vitamins, probably the first one on that bullet point list, if the person does not have macular degeneration. So in other words, they're not preventative, that it would, be a waste and wouldn't be a good idea. Do you agree with that?
Yes. So when they did the studies, they were specifically used for patients who already had macular degeneration. So taking them will not prevent you from getting that. If you're going to get it, you're going to get it. I do have some patients that feel better taking it. I mean, it is just vitamins, and I mean, you are spending money on it, but if it makes you feel better, you can take it. It's usually a combination of vitamin C, E, usually a little bit of zinc, copper, and then the two specific eye vitamins are lutein and zeaxanthin. So those are specifically protective of the macula. So you're welcome to take it, but it won't prevent you from getting it if you're going to get it.
Okay, good to know. Looks like that's all related to that topic. So let's move on.
Perfect. All right. I think this actually is my last topic. So floaters, I'm sure many people have had some floaters at some point. They're very common. Patients see them different ways. So some people will see them as little black spots in the vision. Some people will see them as lines or circles, spider webs. So we have all sorts of descriptions of how they look. They're usually intermittent, so they'll come and go. Some patients will have flashing lights associated with the floaters. For the most part, floaters are nothing dangerous. So you'll see them, again, they'll come and go. There's nothing we can do about them. There's, I think, some research going into what we can do to treat them. I've heard of some laser being used to treat them, but for the most part, we don't do anything because the treatments are not really efficacious. They don't work very well. And then they also can be there can be more side effects sort of associated with the treatment. So if we're going to make your floaters worse, we don't want to do anything that makes them worse. So we usually leave them alone. The way that they look, so occasionally what's happening in the back of the eye, this is all occurring in the space that I had mentioned earlier that's sitting in front of the retina. So there's a gel in the back of the eye. We're born with this gel, and that changes over time. So that's why floaters tend to occur as we get older. You can actually get a little piece of the gel that separates from itself, and that's called a posterior vitreous detachment. And you can see that here in this photo, it's this shadow right here. So this is something we can see on your exam. If we take a picture, you can see it on the pictures. And then as far as what you're seeing is with floaters, again, everybody has a different way of how they describe what they're seeing with the floaters. There's no treatment for this. This will just hang out basically forever. They don't tend to go away. Very rarely do floaters disappear, but it's also rare for them to be consistent and you see them every day, all the time. So majority of patients will have some floater that comes and goes. Maybe every few months you see one, maybe every 6 months, whatever it is. The flashing lights can come when these floaters pull a little bit on the retina, which is the back layer. That's this back layer here. So that little tugging action is what gives the flashes. Again, for the most part, we don't need to do anything. We don't need to worry about this. But if you have had new floaters or flashing lights that you've never had before, or if you have a worsening of your normal floaters or flashing lights, or any changes in vision, you do want to see somebody. And the reason why that is if this floater pulls hard enough on the retina, it can cause it to tear. Now, this is a very, very advanced case here. This is not the norm, but you can see here, these are all tears in the retina, potentially having started from a floater that pulled hard enough on it. Now, this patient really progressed where fluid started to track in the tear and it separated all these layers and it became a retinal detachment. The retinal detachment does need to be fixed with surgery, but usually if it's just a tear, we can fix that with laser in the office. So anybody who has floaters, or if you've heard your doctor say, oh, if you have any new floaters, come back to see me right away. The reason is because we're looking for the tear, because that is something that we can treat and it usually helps the floaters to get better. So the tear is really the big thing. So I tell all patients, anything new, don't wait, just come in. And we may not find anything, which is fine. Better for us to tell you there's nothing there than for you to sit on something that's a tear and then have it progress to something like this. And I have seen that before. So better to come in if you have any new symptoms of floaters or flashing lights. Any questions on floaters?
No, but there are of course, some questions about other things. So whenever you're ready for those.
Okay, I have one more slide just for
Yeah.
general tips, and some of these we talked about, and then we can get to the questions. So one thing I do tell all patients, I actually was asked this today, is, should I wear sunglasses outside? And absolutely yes, especially now it's so sunny, it's summertime, but even when it's cloudy, those rays are still shining down on us. So you definitely want to be wearing sunglasses, and that goes for everybody. Obviously, the risk of eye damage is a little bit higher in somebody who has lighter skin and lighter colored eyes, but it can happen to anyone. So make sure you wear your sunglasses, wear a hat, whatever you need to protect the eyes. When you're looking for sunglasses, the biggest thing is you want to make sure that the tag says it blocks 99 to 100% of UVA and UVB rays. It doesn't matter what color they are, what size, whatever you like is fine. But that is the most important thing. You want to be blocking the rays because the rays are what can damage the eyes. We've already talked about smoking and eating healthily and exercising. Again, general things to keep the body healthy, but it also helps the eyes. Smoking does so much as far as not only macular degeneration, it makes thyroid eye disease worse. I mean, so many things, diabetes. So really important to quit or to not start. Following with your primary doctor also is important. So you want to be looking for things like sugars and blood pressure, making sure you don't have diabetes. All these things can affect the eyes as well. So make sure you get your annual exams with your primary doctor. We did talk about a little bit about the family history. So things like macular degeneration and glaucoma do tend to follow family lines. So if you have someone in your family who has one of these things, you should also get checked out because you're going to be at higher risk. These genes have been isolated for those conditions. So if you know your family history, definitely let us know or your doctor know. It does help us to make sure we're already looking for these things, but it puts us a little bit on higher alert to really find these things. And then lastly, of course, getting your dilated eye exam every year. A lot of these things you wouldn't know you have. I mean, all the early signs for glaucoma, cataracts, macular degeneration won't affect your vision. So you may not, and they don't cause pain. So you may not know you have them. And that's why it's so important. All of these get worse over time. They tend to affect older patients. Your risk for all of them gets worse over time. So we really want to make sure that you have your annual exam. And I put dilated in bold because there's some providers out there that just take a picture of the back of your eyes, but the picture is not good enough. So the picture won't show you your cataract. We won't be able to see the full cataract without being dilated. It doesn't get to the far periphery of your retina, so the very edges, you can't see that without being dilated. So you really need to have a dilated exam to truly see everything, make sure that there's nothing going on. So with that, I'll take the rest of your questions.
Okay, since we're on the topic of testing, a couple people have asked about kind of the minimum tests that should be done every year in order to eliminate, the possibilities of pathology and to correct anything that's going wrong?
So at a minimum, dilated eye exam is really what's needed. I personally will do a photo. So that photo I showed you of the retina, this one, I do this as a baseline for all new patients. And that way, if there is something there, then I will repeat this every year, every 6 months, however often you have to come back to monitor if you have something. If you have something more serious, or if you have something that's more specific, like glaucoma or macular degeneration, then you need those additional tests. So the OCT, which is the photos or the visual fields. Again, depending on how severe the disease is, can be as often as every month. For patients with macular degeneration that we're treating, we get that OCT every month. Or if everything is looking good and very stable and more of the early stages, once a year. So the severity of the disease will tell us how often we need to do those tests. And these are tests that normally, as an ophthalmologist, we're having in our office. Many optometrists don't carry these. So there is a difference between optometrists and ophthalmologists. Optometrists will go to optometry school. Many of them will treat sort of the basic conditions of the back of the eye. As an ophthalmologist, because we go to medical school, we do residency, we learn how to do surgery and procedures, and we treat more of the kind of worsened conditions. So with injections and things like that. So all the procedures and surgeries we're able to do. So a lot of times our referrals will come from optometrists because they don't have a lot of the equipment to be following these things. So it really just depends on how bad it is, and that will tell us how often we need to do all the tests.
Okay, thank you. Question about twitching eye muscles. So perhaps the lid, or if you could address that.
So the medical term is blepharospasm. Usually it's usually not something very serious. It's more annoying. I think the most common cause, unfortunately, is stress, because that's very hard to get rid of your stress. But we do see it in some patients who drink a lot of caffeine or don't get a lot of sleep. So it's very specific things that are usually causing the lid twitching. I mean, I get lid twitching occasionally, usually when I haven't slept very much. So it's a very common thing to have. It usually does not mean anything serious. There are some patients who will use something like Botox to paralyze the muscle, but it's not a long-lasting treatment. It's something that's temporary. So if it's really bad, there are some things out there, but for the most part, we don't do a whole lot for just the eyelid twitching.
Okay. Can you discuss ophthalmic migraines a little bit?
Sure. So ophthalmic migraines are essentially the phenomenon of sort of like getting a migraine in the eye only. So you don't get a headache. Usually what patients will tell us, every patient again describes it differently, but it's some sort of lights or burst, something in the central vision. We will, when I ask patients, I will say, does it look kind of like a shimmering, almost like a disco ball? So it's a very specific phenomenon. It's coming from the back of the eye. It has something to do with the blood flow to the back of the eye. There is no treatment for it. There's really not much we can do. If it's associated with the headache, you can treat the headaches, but otherwise there's not much else that we can do for it.
Okay. And I think this is a related question. They call it ocular migraines. And if you could explain why there's flashing associated with that.
Yeah, so same thing. It's basically again like a migraine in the eye, and it gets something to do with the blood flow. So I don't think that anyone truly understands where they come from, but they can cause this sort of flash or shimmering sort of lights in the eyes. Some patients might even have a little dark spot, and around that dark spot, they see these lights and sort of like again, like a disco ball, sort of glittery, sort of shimmering lights. And again, something from the back of the eye that we don't totally understand. One day we will.
Okay. Is a macular hole hereditary?
I don't believe there's any specific genes. Maybe there is one or two, but I don't, not as much as macular degeneration. So a hole can kind of come from at any anytime, any point. There's some specific things associated with the hole. So having the posterior vitreous detachment, this little guy, sometimes those lead to a hole because they pull on the retina and they cause the hole. Inflammation in the back of the eye can do it. So something like diabetes, the back of the eye environment is very inflammatory. There are a lot of markers in the back of the eye for somebody who has diabetes versus somebody who doesn't. Traumatic holes are also a thing. So if you've had some sort of injury or trauma to the eye, that can create a hole. So usually there's some reason a hole will come. It's not as linked to the genes as something like macular degeneration is.
Okay. A couple of these questions get kind of particular and granular, so I'll just read them as best I can, and you can decide, how to maybe make them more general and do your best with them. This person says they have blurry vision, mainly with close reading, but the prescription hasn't changed. They have Sjogren's cataracts and an epiretinal membrane. As I said, I was going to probably slaughter these as I read them out. So the person uses drops and has plugs, but are there other suggestions to help deal with the blurry vision until the person feels the cataracts are ready for surgery?
In that case, you've got a few things that are really affecting the vision there. So one is the Sjogren's that's causing the dry eye. You've got cataracts, and then the epiretinal membrane occurs back here right in the center where the macular degeneration is. So the epiretinal membranes are little membranes that are sitting right on top of the retina. And those in themselves alone can cause varying degrees of vision changes. So that's a much more invasive surgery to remove those. We can remove them, but it's much more invasive. So most surgeons won't go in to remove that until you've had cataract surgery. So if it's the membrane that's causing vision changes, there's, if it's bad enough, we'd probably go that route of having surgery for that. If it's the cataracts, yes, you want to just wait probably until you need cataract surgery. As far as the reading goes, you can always up the reading prescription. So anybody who's got trouble with reading, you can change your glasses whenever you want to. Going higher on a reading prescription will not hurt the eyes. It won't cause any damage. You can go a little bit higher. You can get them from the drugstore nowadays. It's very easy to change your glasses, especially for reading. So, try different ones and see what works for you. But in this particular case, there's a few different things that's causing the vision change. So it's going to be hard to pinpoint which one it is without actually doing the exam. But those are some things, at least you can, change the glasses if you want to, and then you can really optimize the dry eye, whether, it's with more drops or prescription eye drops, doing ointments, gel tears. I think a lot of people don't put those to use. So those can be really good to use also.
Okay, thank you very much. And we've got one more question, and I will just mention that, that if we didn't quite get your question answered, or if you have a question, please go ahead and put that in the Q&A. But I think this is the last one we have. This one is about posterior vitreous detachment, and they're asking, do the risks outweigh the benefits in surgery sometimes, and are there other solutions?
So if you have a vitreous detachment, we will almost never do surgery. So for floaters, very rarely is surgery done for floaters, because for the most part, they're intermittent. They don't happen a lot. There's much higher risk of doing surgery to either remove this detachment, this vitreous detachment, or to improve floaters, because you're having to go under anesthesia. You're going into this back space in the back eye of the eye here that's much more delicate than, let's say, just having cataract surgery. And so the risks for doing surgery for floaters usually far outweigh your benefit that you're getting from it. Now, if you have debilitating floaters, so if you're seeing them all the time, you cannot function, you cannot do what you need to do, then yes, surgery might be the best way to go, because then you can remove the gel in the back of the eye and the floater should get better after surgery. But again, you really have to see weigh those risks versus the benefit you might get from it. Because if something happens during surgery, going under anesthesia, and this is usually general anesthesia now for the retina surgeries, you really have to see, is it worth it to do surgery just for your floaters? So we don't really tend to do surgery for the vitreous detachments. Now, retinal detachments, yes, there's no way to fix those without surgery. So you have to have surgery for a retinal detachment. What they do is we'll remove the fluid that's in between the layers. Usually you get laser around this area. And then the eye itself, we take out the gel so that it doesn't pull anymore on the retina. And then you fill that space either with a gas or oil, and that helps to tack the layers back on. The recovery is much longer. You have to usually keep your head down in a face down position for many hours every day to really help to get those layers to get tacked back together. So that's a much more, longer surgery, longer recovery, but it is the only truly the only way to fix a retinal detachment.
Okay, well, thank you. Thank you for answering our questions, even when I wasn't able to read them very well. So lots of really great technical information here. I think that is all of our questions. I'm kind of delaying here just in case somebody wants to type something in if we didn't quite get the question answered, but it seems like you covered everything. So thank you so much, Dr. Gupta. This was wonderful information. And as I had mentioned, this program is recorded. We'll be sending out some additional contact information and resources following the presentation tonight. If you are just watching the recording and didn't attend tonight but would like those resources, please just email me at ce@wheatonlibrary.org. That's CE for community engagement @wheatonlibrary.org. And I would be happy to send those out to you. So we will add this to our wealth of recordings. Again, thank you so much, Dr. Gupta, and have a great night, everyone. Take care.
Thanks for having me.